to AETCM, the emergency medicine channel. Today we will be dealing a case of altered sensorium which presented to our ER. Can we start, sir?
Yes.
A 60-year-old female was brought to our ED with complaints of altered sensorium since last 2 days. On initial 10-second assessment, patient was drowsy but she was conscious and oriented and she was obeying commands. Primary survey, her airway was patent, there was no pooling of secretions or gurgling sounds or hoarseness. Breathing, her respiratory rate was 16 per minute with a saturation of 98%. Bilateral air entry was equal and there was no added sounds. Circulation, her heart rate was 100 per minute with a blood pressure of 160/80 with a mean arterial pressure of 106. All peripheral pulses were felt equally and bilaterally. Disability, her Glasgow Coma scale was E4, V5, M6. Pupils were 2.5 millimeter reactive, sir. Exposure, she was febrile and her GRBS was 145. Hypothermia was prevented by blanket. Since there was a history of altered sensorium and hypoglycemia was prevented, I wanted to check for any electrolyte abnormalities and all. So our blood gas analysis will show the sodium value and all, and carbon dioxide value. So I asked for a blood gas analysis which was showing a pH of 7.365, PCO2 of 24.9 and bicarbonate of 13.9. It was showing a metabolic acidosis with a creat of 1.1, lactate of 1, PO2 95, PCO2 of SO2 of 97 and the anion gap was 8. So it was a normal anion gap metabolic acidosis.
What are the reasons for it?
Normal anion gap metabolic acidosis, you can usually some causes like diarrhea or drugs like carbonic anhydrase inhibitors or IV fluids, hyperchloremic normal anion gap metabolic acidosis, then renal tubular acidosis, adrenal insufficiency can cause.
What is the blood sugar value?
145. So she had a normal anion gap metabolic acidosis. Other than that, since she was conscious, I didn't go for any other intervention at this moment. Then I went for a ample history, sir. There was no allergies. She is a known case of CLD, child day status, non-alcoholic liver disease, sir. She is hypertensive on losartan. She is
What is the age of the patient?
60.
60.
She is hypertensive on losartan.
She is not having hepatitis B, hepatitis C, non-alcoholic. What may be the reason for the liver disease?
Non-alcohol NASH, sir. She's not having any other hepatitis C or B, not an alcohol.
What may be the pathology?
Hepatitis.
It is one of the reasons. Most important thing is female patient who is having chronic liver disease, immune mediated or autoimmune hepatitis is the one of the commonest differential diagnosis. Otherwise, without any cause, cryptogenic cirrhosis, both are possible. Okay, since there is no other diagnosis was made in the past.
She is diabetic on metformin 500 mg BD and linagliptin 5 mg once a day. Events. What happened was she was having acute onset of vision loss like 1 week back, for which she was diagnosed to have a vitreous hemorrhage with a rheumatogenic retinal detachment of the right eye, and vitrectomy procedure was done 4 days back, and she was started on ciprofloxacin, gatifloxacin eye drops and acetazolamide eye drops and acetazolamide tablets 200 mg BD. After that she was discharged, and in the house she past 2 days she is lethargic and she was found drowsy, and there was poor oral intake. There was no history of any melena hematemesis, no history of any paracentesis or tips recently.
What was the urine output in the last 2 days?
Urine output, it was normal, sir. No history of any trauma, reduced urine output, breathing difficulty, fever or involuntary maturation. She was passing 1 to 2 stools per day. On examination, head to toe examination, there was no pallor, icterus, cyanosis, clubbing, lymphadenopathy or edema. Head to toe examination, decompensated cirrhosis features were not seen, sir. There was no parotid enlargement, clubbing or spider nevi, palmar erythema, no caput medusa, edema or lower limb edema was seen. Central nervous system examination, higher mental functions were normal. She was obeying commands, but flaps were present, sir. Vision on the right eye, she was able to see finger movements. Left eye, vision was counting fingers were there, sir. Then tone was normal. Bilateral plantar was withdrawal. Reflexes were normal. Cerebellar functions were normal. Sensation were normal. Constructional apraxia, since she is having vision problem, constructional apraxia couldn't be done, sir. Per abdomen examination and GAT examination, her tongue was dry, sir. Inspection of the abdomen was somewhat normal, sir, normal appearing. Umbilicus was in normal position. Palpation, it was not distended and there was no ascites on palpation. Then there was no hepatosplenomegaly. Percussion was tympanic and bowel sounds were present. Cardiovascular system examination and chest examination were within normal limits, sir. So I came to an impression that it is a case of CLD, child age status, currently decompensated with grade 2 hepatic encephalopathy, maybe secondary to dehydration and normal anionic of metabolic acidosis because of carbonic anhydrase inhibitors, acetazolamide. And
what are the other reasons for altered behavior in chronic liver disease?
Altered behavior, if the patient is having, it can be because of IC bleeds, sir, because of coagulopathy.
Okay.
Then alcohol withdrawal or Wernicke's encephalopathy can be there.
Okay.
Delirium tremors can be there, sir. Hypoglycemia.
Then
Hyponatremia.
Then
uremic encephalopathy.
here uremia is different issue. Okay, uremic encephalopathy secondary to hepatorenal. Then
Benzodiazepine, drug induced.
okay, any sedatives, overdose, all these things.
High protein intake causing a
High protein
decompensation.
intake. Then one more, electrolyte imbalance you are not telling.
Hypokalemia.
Hypokalemia is the most important cause that should have told first. Okay. So hyponatremia you see in many cases of chronic liver disease that may not be clinically significant. Why it is not clinically significant?
Dilutional hyponatremia.
Mostly it is dilution. Whereas hypokalemia is most important cause for triggering hepatic encephalopathy. That should be ruled out and treated properly, especially when the patient is on diuretic like this. What is the potassium?
Her potassium was 3.2, sir.
Okay, is it normal or abnormal?
It was low, sir, abnormal.
What is the average reduction in the potassium when it is 3.2 in your body?
Basically,
3.2 in serum. What will be the potassium deficit in the body?
Every 1 ml and around 200 will be liquid.
Okay, so around 150 will be deficit here. So if already patient is having a chronic liver disease, 200 or 300 deficit can definitely produce hepatic encephalopathy. Like that, it can be due to what you told, dehydration also can produce. But hypokalemia is one of the most important causes that should be corrected first itself.
Her IVC was checked, sir. It was 0.7 centimeter collapsed. Ultrasound abdomen was showing CLD features with portal hypertension, no ascites. Blood investigation showed a total count of 8,000, platelet of 1 lakh, hemoglobin of 12.8.
Why platelet is 1 lakh? What is the reason?
CLD induced thrombocytopenia, hypersplenism.
Hypersplenism. Secondary to hypersplenism. Thrombocytopenia can be there in liver disease as such.
Then her sodium was 134, potassium was 3.2, and ammonia of 74.3, sir.
Okay. What is the importance of ammonia here?
Ammonia, if it is not a direct indicator, but it will be elevated in decompensated cirrhosis.
It is an indicator of chronic liver disease, but it will not indicate the severity of the disease. Like you get sometimes 200, 300 ammonia, that will not correlate with your clinical feature. But whenever there is an hepatic encephalopathy, this will be definitely elevated. It may not be elevated like what you are seeing clinically. Okay, that correlation is not there.
LFTs were within normal. So bilirubin was 0.5 with the direct bilirubin was 0.19. OTPTs were normal and INR of 1.09. All other parameters were normal. RFT.
Albumin globulin ratio?
Albumin was 4. Globulin was 6, sir.
Okay.
So
that is the only indication of chronic liver disease. Why this SGOT SGPT is normal in chronic liver disease? Normally we have a thinking that whenever there is liver disease, SGOT, SGPT has to be elevated. But this is not happening in most of the diseases. Acutely, when there is an inflammation of large amount of cells, you get SGOT, SGPT elevated. Here there is inflammation, but the number of cells are very low. So you may not see the elevation in a normal liver, like what you are seeing in paracetamol poisoning. Here also there is ongoing inflammation, but since the number of cells are coming down, slowly the SGOT, SGPT levels will come down. Whereas albumin globulin ratio will give a very good indicator for chronic liver disease. Any other indicator for liver failure? What is the indicator for liver failure? Lab investigation. INR. What is INR?
1.09.
1.09. Okay. So functional part is working, but the number of liver cells are reduced. Only 25% of the liver cells are enough to survive for a normal person. So that may be there. So functionally it is working, but as a whole liver cells are coming down.
Urea was 36, sir, and creat of 1.1, sir. Okay. Urine routine was normal.
What is the earliest sign of hepatorenal syndrome? You were talking about hepatorenal syndrome. Can you tell this hepatorenal syndrome? Early lab investigation. What will be the hepatorenal one? Failure. Hepatorenal syndrome means kidney failure. Proteinuria will be there, but creatinine may be normal most of the time. If you don't treat this patient after 2-3 days, creatinine can be slowly increased. Okay, so that time only you'll notice. But now itself you can ask for a urine protein to know what is a kidney perfusion and all. Okay.
So this patient is having a decompensated cirrhosis secondary to dehydration, hypokalemia. Hypokalemia itself causing aminogenesis and increased ammonia, and dehydration secondary to carbonic anhydrase inhibitors.
Okay. So how do you manage this case? And one of the most important problems we are facing in ICU is these patients most of the time they will become agitated, and you may have to treat the agitation, pain management, intubation, ventilation, all these things. Drugs are very important. You can tell all these things.
Comorbidities?
She is having CLD, diabetes, hypertension, and recent history of vitrectomy surgery. So when we are managing, we should manage according to airway, breathing, circulation. At present, this patient's airway is patent and breathing is normal. Circulation wise also it is normal, but disability, she is having dehydration and hypokalemia is also there. So we should correct hydration and we should correct the hypokalemia, sir.
How do you correct the hypokalemia?
So this patient's potassium is 3.2. So at least 50 to 100 milliequivalents deficiency is there. So we should put an EG.
And ongoing, every day you require some more potassium.
Yes, sir.
The deficit is somewhere around 150 here. What is the normal requirement? 1 milliequivalent per kg. So if it is a 60 kg female, another 60 you have to add. So your daily requirement is 60 milliequivalents. On top of that is deficient of 150. Okay, so it will be 200 you have to correct. How do you correct it?
To correct 200 in a day, we should put a center line and we should correct, sir. If we are correcting through a peripheral line, we can correct only 20 milliequivalents through a peripheral line and at a time, and 40 milliequivalents through an EJV, sir. Okay. So this patient EJV was placed and we have corrected 40 milliequivalents each every 5th hourly, sir.
Okay.
Then oral supplementation of potassium chloride was also started, sir. And this patient was started on IV fluid management.
What is the urine potassium in this patient?
Urine potassium was coming around 10, sir. So
okay, so there is no increased loss through the kidneys. But when the patient is on diuretic, you have to think that this might have gone through the kidneys, but at present there is no need to do any action. Okay, but do you recommend any drug to prevent potassium loss through the kidneys? At the same time, you want to remove some water.
Spironolactone.
Okay, continue.
Then her ammonia was 74, sir, and her stool out. According to bystanders, the output is 1 to 2 a day, but we want the output of at least 2 to 3 soft stools per day. So we should start her on lactulose, sir. Lactulose 35 to 40 ml should be given thrice a day to get an output of at least 3 stools.
Is a diabetic? Can we give lactulose?
Yes, yes, sir.
Non-absorbable.
It's a
non-absorbable sugar.
So that is very important. Many doctors think that it's a sugar, they don't give that. Actually, we can give it.
So lactulose can reduce the ammonia also. It will promote the stool, and also it can reduce the gut ammonia level and
It will
ammonia.
not reduce the ammonia, it will reduce the ammonia producing
Bacterias.
bacteria's overgrowth, that's all. Directly it will not reduce the ammonia, okay. But ultimately it leads to the reduction in the ammonia production.
Then she was started on gut sterilization. Rifaximin was started. 550 milligram BD was started, sir.
550 milligram tablets are not available.
Or if then 400,
It is
400
200, 400. So you give 400 milligram
TAD.
Okay, it is not available in India.
Then she was started on a low protein and high carbohydrate diet, sir. So protein requirement for a CLD patient is 1 to 2 gram per kg per day, and carbohydrate 35 to 40 kilocalories per kg per day, and that was maintained. And an ophthalmology consultation was kept for the eyes, sir, and carbonic anhydrase was stopped and it was changed to drops only.
Okay. Now you can discuss about pain management.
See, what are all the preferable drugs for RSI as well as the sedation and pain management?
Yes, sir. CLD patients are benzodiazepines usually can cause a prolonged sedation and decompensated cirrhosis in case of CLD patients, sir.
Okay.
So drugs like midazolam can have a prolonged action since it is metabolized in the liver. If at all the patient is agitated, centrally acting alpha agonist can be used, like dexmedetomidine can be used, sir. Then for
what is the main advantage of dexmedetomidine?
It will just reduce agitation. It will not cause much of a arousable.
So we can assess the mental functions. Okay, good.
And for intubation, sir, intubation induction agent, since she's
is there any scoring system for delirium, sedation, agitation? So there is a pain scoring system. Is there any other methods? There are scoring systems also. Scales are there. Okay, agitation and sedation separate scoring systems are there. Okay, next. So why they are having a scoring system? We want to give only appropriate necessary dosage of the drugs, not to overdose the patient. So whenever we are administering, we have to reassess after a few hours, and then when necessary we can repeat the dosages. Otherwise, usually common regular at the interval of 3 hours, 4 hours. So there will be variations in the metabolism as well as elimination, duration, and the aged person with liver disease. So according to when and where indicated, we can give appropriate dosages. Okay. RSI.
RSI, sir, induction agents we can give etomidate, sir. So it is hemodynamically, it will not produce any instability. So and for pain we can give fentanyl, sir.
Okay.
Then for paralytic agent we can give either depolarizing or non-depolarizing agents can be used, sir. Boxaxenylcholine and non-depolarizing agent like rocuronium can be used, sir.
Any other precaution?
In CLD patients, usually there can be issues with the upper airway because they will be having facial swellings and all. Upper airway obstruction can be there, sir. Obesity, the parotid enlargement will be there. So there can be difficulty in bag and masking for this patient. And ascites, if the patient is having ascites, large abdomen and all, there will be difficulty in ambuing. Capacity will be reduced.
Functional residual capacity will also be reduced.
In view of the age also, all functional residual capacity will be decreased. Okay. Then. So we are positioning the patient before induction, during intubation, other things we have to keep in mind. And when we are putting the lines, we have to be careful about any bleeding, undue bleeding, prolonged bleeding. These are all the things.
Anything else? If the patient is agitated, in what drug they?
For agitation, we can give dexmedetomidine infusion.
I told that.
Okay. Anything else you want to add?
Pain management.
Pain management.
Usually, actually, as a single dose, we can give
Paracetamol.
Okay.
Pardon?
Okay.
Single dose paracetamol can
1
be
gram
used.
can be given. Okay. What is the upper limit of paracetamol in liver injury? So already like CLD patients, not liver in acute liver injury. CLD patients, what is the maximum dose you can give? Normally, it is told normal patient liver injury will produce around 8 grams. Up to 4 grams we can give in even chronic liver disease, but normally we don't give. We give maximum 1 gram. We never try to try for that. Like we never go to 4 gram and try what is written in books. But 1 gram and all safely can be given. After that, you have to try for other type of drugs like opioids. Opioids also we should be using very carefully, because lot of complication like constipation, altered behavior, everything can occur, and it can even reduce the GCS, so we will not be able to assess the patient. It will be a difficult situation to handle this type of patients.
Even NSAID also will be difficult.
NSAID also we cannot give because it can produce again liver injury. Okay. How to prevent hepatorenal syndrome in this type of patients?
Adequate hydration.
Hydration is most important then.
Assess.
If the BP is coming down, what all things you can do? Ascites, hydration is one thing.
Albumin
can be given.
Terlipressin.
Okay. Noradrenaline also explained in some guidelines, but terlipressin will be an effective drug. Okay.
Any anti-cerebral edema measures?
You want to give?
In this patient, no need, sir.
Okay.
But otherwise, if the patient is going for cerebral edema, we can give hypertonic saline, head and elevation can be done, sir.
When there is raised intracranial tension, we have to be very careful during the procedure of laryngoscopy, intubation, and maintenance on ventilation.
Another important problem in this type of patients is seizure. How do you manage?
Seizure management, benzodiazepine for acute management.
Benzodiazepine, okay, acutely you can give, but it will produce again problem like this. You can use definitely in acute status epilepticus, you have to control it. Okay.
Levetiracetam is the best drug for liver disease patients.
Okay. Levetiracetam safely you can use, whereas other drugs like phenytoin, phenobarbital, again it will create problem. Okay. Benzodiazepine you can give, but that also produces problem afterwards. Okay, if it is status, definitely you have to give. Okay, anything else, sir?
If at all you want to go for benzodiazepine, the shortest duration action is only midazolam. Unpredictable action of diazepam and lorazepam should not be given.
Okay.
Finish.
Thank you.
Good presentation.